So hello, welcome everyone to History Day 2022. Just a quick introduction to what History Day is. History Day is a free one-day event that brings together students, researchers, and anyone who's interested in history with information professionals from libraries, archives, and research organizations. This year, the theme is human discovery, experiencing science. And for today's event, we will be exploring collections on the history of science and technology in their broadest senses, including everyday history experiences and impacts of science and technology on ordinary people. And we have an exciting program of events lined up throughout the day. A link to the program is on the slide that you can see on the screen now, as well as a link to our Discover Collections gallery, where collections from across the UK and beyond have come together to share their collections and resources for you to view on this day. And I also would encourage you to follow us on the hashtag HisDay22 on Twitter, so you can catch up with a lot of extra content there. Kate, do you want to quickly introduce the Being Human Festival as well?
Yeah, hello everybody. I'm Kate Wilcox from the IHR Library. This event is part of the Being Human Festival, which is taking place across the UK between the 10th and the 19th of November. And Being Human is the UK's national festival of the humanities, run by the School of Advanced Study, University of London, with generous support from Research England in partnership with the Arts and Humanities Research Council and the British Academy. You can find out more about the festival and see the full programme on the festival's website, beinghumanfestival.org. The festival can be found at Being Human Fest on Twitter, Instagram and Facebook, and the hashtag is BeingHuman2022. Please help us keep as many festival events as possible free and to improve the festival in years to come by filling in the feedback survey that you'll be emailed. Your feedback is incredibly valuable. And if you'd like to help support the festival by making a donation, you've been sent a link in the emails that you've received. Thank you, and now we'll hand over to Philip to start the session.
Thank you very much, Kate. My name is Philip Murphy. I'm Director of History and Policy at the Institute of Historical Research. We've got a fantastic panel for this session on public health histories and public policy. And it's a wonderful topic. I mean, obviously there's been a huge growth in the history of medicine and health in recent decades, partly stimulated by funding from the Wellcome Trust, of course. It's fascinating in itself, but I suppose from my perspective, history and policy perspective, I'm really interested in how a historical understanding can help us analyze and understand more recent medical emergencies and help make for better policy making. And in this context, what do the special collections, incredibly rich special collections available to us in the UK, how do those help us to understand those issues? We have an ideal panel to help us answer that. Let me introduce the panelists. We're going to start with Katie Birkwood, who's the Rare Books and Special Collections Librarian at the Royal College of Physicians. She manages a collection of approximately 50,000 books spanning 5.5 centuries of the history of medicine, and works as an integral part of the college's archive, heritage library and museum team to interpret medical history for diverse audiences. With her is Victoria Cranner, who's the archivist and records management at the London School of Hygiene and Tropical Medicine. She established the school's archive service in 2002 and is responsible for managing, preserving and making accessible the historical records of the school and operating their records management service. The third member of the panel is Dr. Eleanor Brenner, who is Research Development Specialist at the Wellcome Collection in London. Her research explores health, religious culture, and the history of the book in medieval France and England. She's published on leprosy, plague, and public health, as well as charity and monastic medicine. She's co-editor of Social History of Medicine. A fourth panelist, Isabel Chevalot, can't be with us, but she's provided a video presentation, which we're going to play after Katie, Victoria and Alma have made their initial presentation. For the past 12 years, Isabel has worked as an assistant librarian at Guildhall Library, a major public reference library that specialises in the history of London and traces its origins back to the original library at Guildhall, founded in the 1420s. So a very long pedigree there. Thank you all for joining us. You know the protocols for Zoom meetings very well. Please make sure that you're muted while the presentations are going on. You'll be able to unmute yourself to ask questions. But in the question session, either use the chat function and do start to pose questions as the speakers are giving their presentations. You don't have to wait until the end. As chair, it's always reassuring to see some questions in the chat before the presentations are finished. Or raise a virtual hand and I'll bring you in. I think the interaction is going to be really important to us today, and we will be recording this session, so please do bear that in mind. So without further ado, I'm going to ask Katie to give the first presentation. Katie, thank you very much for joining us.
Thank you, Philip. Thank you for that introduction, and thank you to the History Day organisers for this invitation to be part of this great panel. So as Philip said, I'm the Rare Books Librarian at the Royal College of Physicians, but today I'm going to be talking about some of our archival collections which speak to these issues of people's health histories and public policy. The Royal College of Physicians is England's oldest medical royal college. We have a history that spans 504 years. We were founded by Henry VIII in 1518. And the original goal of the college, our founding mission, was to regulate medical practice in London and then later across England and Wales, and to license physicians to practice if we deemed that they were sufficiently qualified. But we were also instituted to, quote unquote, protect the rude and credulous populace, both from unlicensed practitioners, but also from the dangers of ill health and disease. And we have a long history of public health involvement, although not necessarily a continuous history. It's certainly a valid criticism to note that the college has been rather on-off in its involvement in public health. But some of the earliest interventions surround plague outbreaks in England back as early as the late 16th century, with advice published by the college during major outbreaks in the 1630s and during the Great Plague of 1665. And then also throughout other health crises that have hit England and indeed the world in the ensuing centuries. So the archives that we have comprise both the institutional records of the college, so the minute books, the account books, the professional correspondence, all those things that make up the history of what the college as a body was doing, but also personal papers of physicians and occasionally of their patients where they relate to health, their own health and care. And so the real value, I think, of the RCP as an institutional archive and repository and source for research is it's a place where the institutional and the private perspectives collide in some expected and perhaps in some unexpected ways as well. So I've just pulled out a couple of examples to get things going today. And the first is cholera. Obviously a scourge of the 19th century in England and across Europe and much of the rest of the world. And the RCP was asked by government on several occasions throughout the 19th century to provide advice to the populace, no longer called rude and credulous at least, but to the populace about what to do about cholera. And it's very common to say that the college wasn't terribly effective, not least because it noted, as in this first little quote I've pulled out here, that cholera, it says, seems to have been very rarely communicated by personal intercourse. This is from a policy paper issued by the college in 1848. And it's often the basis for people saying that the RCP said that cholera wasn't a communicable disease and was passed only through bad air, miasma, stink, rather than through any infectious agent. Now, I mean, we could get into the weeds of quite what they are saying about communication through personal contact as by other means, through infected water. But what I found really, really striking looking at this final report that was produced was that the other comments that the college make could come straight from college policy papers today. They say the disease has almost invariably been the most destructive in the dampest and filthiest parts of the towns it visited. The college would therefore urge the public authorities to take immediate steps to improve the state of sewers and drains. What are we talking about today? We're talking about improving air quality. We've mostly got, well, I was going to say we've mostly got water sorted, but of course there's an awful lot of sewage being pumped out into the rivers and seas at the moment, so maybe this is going to recur as an issue. But we're talking about public health measures like improving air quality in schools, hospitals, places of work. They also, the college, deem it most desirable that parish authorities should at once improve diet, increase the comforts of the poor under their charge, and that the wealthy should form societies for the supply of food, clothing and fuel to those who, though not paupers, still need charitable assistance in the present emergency. And when we think about the inequalities in health brought about by inequalities in social status, access to basic resources like heating, food, arguably also education, certainly safe housing, these comments from the college in 1848 really mirror an awful lot of the issues that are facing healthcare and policy today. So that was something I found really striking in our papers. But the way these reports were brought about was by the college canvassing its members through asking them for their opinions on the subjects of the day. So though they produced one singular report, there is a wealth of evidence that sits in our archives beneath that report that really evidences the confusion and massive opinions surrounding any health situation. So if we move to my second slide, the other example I'd like to draw on is smallpox. And we have a huge wealth of material brought together by the RCP Vaccination Committee in the early 19th century, as well as personal papers relating to Edward Jenner, so letters written to him and some of his notebooks. And it just really fleshes out what can be told as quite a trite story of Edward Jenner introducing cowpox vaccination and some 100 years later and more, the world being rid of smallpox. Haha, everything worked, it was fine. And the granularity that you get from this mass of reports that were sent into the college by its members really sheds light on the issues of the day and the issues of today. So, for example, we had physicians arguing over how actively vaccination should be promulgated and encouraged on people. So we have one who writes in and says, well, one of the problems with people not taking up vaccination is the overzeal of the promoters of vaccination themselves. So blaming people, pushing it on people too hard. There's also issues of medical ethics. It's very easy, I think, from a modern perspective to sneer at people who think that we shouldn't trust what doctors say. But then when you look at some of the things that doctors do, certainly in the past and also today, but maybe we don't always have the evidence for it, we really start to understand that perspective. So in the second quote, we have a doctor who's saying, oh yes, this vaccination works really well. And in fact, I have sometimes persuaded the parents of children I've vaccinated to let their vaccinated children lie with those who haven't been vaccinated yet and actually have smallpox of the unpleasant kind with the pustules and the really bad variety of smallpox. And none of those children that I vaccinated have got it. So that's good, isn't it? So, he's taking real risks with the health of these children, but it turned out all right in the end. And then lastly, from Jenner's own papers, and this is where I'll end, we find him writing to his friends and saying things like, you'll have seen by the papers how I am annoyed by a set of blockheads who write about the imposition of vaccination without really knowing what's going on with it. And anti-vaxxers were just as much an issue in Jenner's time, and he got just as cross about them as I think many public policy, public health experts would do today. So there we go. That's a very small, hopefully tantalising glimpse into some of the things we have in the RCP archives. Thanks.
Very interesting indeed. Thank you so much, Casey. Over to you, Victoria, for the next presentation.
Good morning, everyone. Thank you very much for inviting me to speak. I'm going to briefly outline two examples of how our archive collections have impacted and contributed to the response to recent epidemics. So I'm going to talk about the Ebola epidemic, and then I'm going to start with our HIV and AIDS papers. At the end of 2018, we were contacted by the Infected Blood Inquiry. So this is an independent public inquiry established to examine the circumstances in which patients treated by the NHS in the UK were given infected blood and infected blood products throughout the 1970s and 80s. Many of these people were haemophiliacs who regularly were given blood products. The inquiry, which is still ongoing, examines why patients were given infected blood, the impact on their families, how the authorities, including the government, responded, the nature of any support provided following infection, questions of consent, and whether there was a cover-up. It's reported that at least 2,400 people died after contracting HIV or hepatitis C as a result of the blood products. And as many as 30,000 people became severely ill. And the chair of the inquiry has recommended that victims should receive at least £100,000 in compensation. So when we were first contacted, we thought we didn't have any relevant records as we weren't involved in clinical practice as an institution, and we did not give infected blood to patients. However, the inquiry were really interested in looking at records from the time, as these provided evidence of how infected patients were treated by society, and they were also trying to uncover how much the medical profession knew. So the lawyers from the inquiry requested thousands of our documents. We have 8 collections relating to HIV and AIDS. Some of these more relevant than others, but a couple of really relevant collections include the Kay Wellings collection. And this includes a set of press cuttings organised by year from 1983 to 1993. And it gives a real insight into what the British press was saying at the time about AIDS. And as you can imagine and think, there's been quite a lot of recent programmes on about kind of 40 years since the beginning of HIV and AIDS. You know, there was a lot of derogatory and disgusting comments in the press. So this information was gathered to see how people were treated. And then another relevant collection is the AIDS Social History Programme. And this documented the history of the disease as it happened and aimed to capture the response of policymakers and charity organisations to the disease. And these papers include papers of central government, regional government, medical and voluntary organisations, all relating to the epidemic. After reviewing many of our documents, there were requests for thousands of scans, which we provided to the inquiry, and we know that some of these have been used in the public inquiry. And this really demonstrates the value of this collection. It is one of our most highly used collections. We get lots of researchers asking about it, and it's very varied, as I said, from kind of press cuttings. We've got lots of posters, ephemera, and material from grassroots organisations as well, which I think is really important. So I'm going to move on to my next example, which is relating to the Ebola crisis in 2014, and really how our archives were used to make really important decisions about how to treat the epidemic. So our former director, Sir Peter Peer, he's called the co-discoverer of Ebola. He's written that in his book in the 1970s. And we hold these records as part of his deposit. He did a lot of work on HIV and AIDS, and the Ebola papers are quite a very small part of this collection, which he deposited. So in 1976, Piot worked as a lab assistant in the Institute of Tropical Medicine in Antwerp, and he was in the team that isolated the Ebola virus and subsequently joined the World Health Organization investigation into the Yambuku region in Zaire, which is now the Democratic Republic of Congo. And that's where the epidemic was centered. This lethal disease infected 318 people and killed 280 in a 2-month period and spread widespread fear across the region. And then, as we know, in 2014, a new epidemic began in Liberia, Sierra Leone, and Guinea. And in this, 11,000 people died, and this caused fear across the world. So during the early stages of the 2014 Ebola epidemic, infections were rising beyond levels seen in previous outbreaks, but information was extremely limited. In many past outbreaks, hospitals had played a substantial role in disease transmission, but it was not clear how Ebola had spread through communities. To answer this question, researchers from NSHTM revisited original patient data from the 1976 outbreak, which was held in the archives. This included data about the likely source of infection, as well as the date of symptom onset, and whether the patient recovered or died from the disease. And combining the data with mathematical models, it was found that changes in behaviour in the community, rather than the closure of the hospital, that brought the original outbreak under control. And this suggested that the epidemiological conditions that existed in 1976 would therefore have the potential to generate a much larger outbreak purely by chance. The data gathered from the archives gave researchers crucial values, such as duration of infectiousness, that could be used to study the 2014 epidemic before more up-to-date information became available. And at LSHTM, staff were encouraged to go to Africa, African countries, and were given time off and sabbaticals to fight the crisis. And the information that was gathered from the archives was incredibly important. And it really demonstrates how a small collection of handwritten notes of a fairly unknown disease, when we kind of took in the papers, I don't think I'd heard of Ebola, but was crucial in the subsequent outbreak. So it really demonstrates the importance for the retention of these medical records. And I think there are parallels. A lot of the researchers that worked on the Ebola outbreak then went on to work on the COVID-19 outbreak. And I'd actually heard of the R number through this. I was explained about kind of the cycle of infectiousness. So when during COVID, or the R numbers, it made a bit more sense to me because of this. But I shall stop there, and I'm obviously happy to answer questions later on. But thank you.
Thank you very much indeed, Victoria. So can I ask Elma to give the third presentation, please? Welcome, Elma.
Thank you very much, Philip. It's great to hear those two talks already getting us thinking about responses to health crises and the kinds of materials that we can find in libraries and archives. I wanted to look at an earlier period to think about Europe in the Middle Ages, from the kind of first outbreak of plague in the mid 14th century up to around the year 1500, which is a very, arguably quite an artificial cutoff point for the end of the Middle Ages. And actually, when we think about epidemic illness, many of the themes, problems, and strategies continue across that divide into the 16th century and beyond. So hopefully some of the things that I'll talk about have a broader chronological relevance as well. And I also wanted to share just a few of the materials that we have in Wellcome Collection that relate to epidemic illness. And I thought that a good starting point was really to kind of say that a question that comes up at least twice a year, I would say, is what have you got on the Black Death? Whether it's a media inquiry or an early career researcher, or someone else who is, rightly so, I would say, would come to Wellcome Collection as a museum and library that is dedicated to the full range of matters relating to human health, and say, what have you got about this, the first plague outbreak in Europe? And the answer is, it depends how you frame what you're looking for, because so as a collection, we don't have an original chronicle from the 1340s, 1350s. We don't have another form of narrative account of the Black Death. We don't even necessarily have an artifact from those particular decades. Although we do have, we have a number of medieval manuscripts, but I can't point to a particular one and say that is the one that is from the period of the Black Death and reflects the Black Death. However, like other collections in the UK and around the world, we have numerous materials that do reflect experiences of plague and other epidemic illness, and the human strategies to deal with those in terms of protection, prevention, and occupying a position of resilience. And for me, those things have been really important to reflect on in the past few years as we've lived through experiences of pandemic illness ourselves. So the image I've got on the screen here is from, it's a late 15th or possibly early 16th century manuscript written in Middle English containing health-related texts. Mostly about human anatomy, so the texts are not about plague specifically. And at the end of the manuscript, there are a sequence of anatomical images. And this is an image called the Wound Man, which you also find in a number of other late medieval manuscripts and also early printed books. So it's quite a widespread image that is redrawn in different ways, but usually shows a human figure, a male figure, unclothed, with all kinds of objects attacking the body, and so kind of external attacks. It's violent, and you know, a key question is, what's the purpose of this image? And I think we need more reflection on that, but it has been suggested that it's supposed to be a kind of useful tool for medical practitioners to understand the range of injuries they might have to deal with. In this particular image, which is unusual, we also have plague buboes. So you can see on the armpits and in the groin, there are these circular swellings that are basically reflective of the manifestation of one of the forms of plague. And this is very interesting because that disease would manifest from within the body. It wasn't that that person was attacked with a dagger and those plague buboes appeared, but it's coming from within. But it is suggesting that this is part of the repertoire of urgent and dangerous illness that a medical practitioner would need to think about, and also that it was perceived as a violent attack, as something that was, you know, deadly, just like these violent kind of objects that are kind of really inflicting serious injury on this body. And so really, I thought that image was useful for thinking about the place of plague in late medieval culture. Also the fact that it forms part of the broader framework of thinking about health. So it's considered among the repertoire of things you need to know about, you need to be concerned about. And also I think it's interesting also, I think art historians have paid a great deal of attention to this particular image. It appears on the cover of various books, and some of you joining this session may well have seen it before. This figure is very passive looking. It's as if, you know, there is a bit of a sense of powerlessness, which I think is something we need to think about with late medieval European experiences of epidemics, in terms of what you could actually do. Certainly once the plague buboes appeared, what could you do? There was not a cure, there was not an obvious treatment at that point. So if I could have the next image, please. So this is a different kind of image, but it also relates to epidemic illness. And this is it's a woodcut printed image. It's the title page to a book, which was a short tract about how to deal with the pox, or the French disease, which was a new epidemic illness that suddenly appeared in Europe in the 1490s. And this is this particular pamphlet was printed in 1496. So it's a rapid response text. And the pox, French disease, roughly equivalent with modern day syphilis, was very quickly recognized to be a venereal infection. And it had serious effects, causing very nasty swellings and blemishes, fever, also mental disturbance, and also in a lot of cases quite rapidly death. And this image is really evoking, well, really something that's incredibly important for late medieval Europe is the religious response. So in terms of causation, there was an understanding that epidemic illness was caused through corrupt air, or miasma, and there were numerous well-documented public health measures, such as avoiding overcrowded places, making sure that there were not open latrines or contaminated water in public spaces, or rubbish, all of which would emanate nasty smells and corrupt air. And in the case of the pox, the specific epidemic, because it was a venereal infection, there was also a warning against intercourse with someone who was infected. But crucially, underlying all of this thinking was the understanding that illness was associated with sin and was divinely inflicted. And so really the first thing you needed above all was to take a look at the state of your soul. And collectively as a community to take a look at morality and religious behavior, and attention to devotion. And so in this image, we see the seated figure of the Virgin with the Christ child, and the Christ child is emitting these healing rays on two diseased individuals who are in a pose, a gesture of repentance, kneeling down. And so they're identifiable as ill by the blemishes on their faces and their bodies, but we have the impression that they are going to be saved, they are going to recover, because they are paying attention to the state of their soul. In the foreground of the image, we have a figure who has succumbed. So they're not going to make it. The underlying message is that they did not repent. So that image is packed with information, really. There are other things going on in there as well, which I don't really have time to talk about right now. But it's another of those images that really can tell us so much about the place of epidemic illness in late medieval communities in their culture. And finally, I'll just say something very brief about what people did, people's resourcefulness, their resilience. And also the sense that you might be able to bypass a health crisis altogether if you kept yourself healthy. So a lot of thinking has tended today, I think there are, in terms of our generalizations about the Middle Ages, we tend to say they didn't have our medicines. You know, they couldn't necessarily treat an infection with antibiotics. So, you know, disease was dangerous. What do people do? You know, how do they live with this? One of the key things people did was to try to stay healthy. So they paid attention to their diet. They thought about how much sleep they got. They took exercise. They took care of their emotional state, things that we think about today, and they took very seriously. So the strategy was stay healthy, keep your body resilient. And finally, to mention that there were treatments. At Wellcome Collection, we have a rich collection of late medieval medical recipe books that show treatments based on the use of natural ingredients for a wide range of problems, including the plague. So people did have remedies that they turned to. They also used a wide range of remedies for the same problem sometimes, showing a flexibility in the approach to health. So I'll stop there, but really it's a sense that late medieval European communities had a number of strategies and resources at their disposal in dealing with these crises that they encountered regularly and on quite a significant scale. Thank you.
Thank you very much indeed, Elma. We're going to go to a video presentation from Isabel now. While that's being set up, can I just say that we're going to go straight in. Lots of questions have been occurring to me. I'm sure they've been occurring to you in the audience. So please start putting them into the chat and be ready to come in after this with your questions to the panelists. So if we could have the video now, please.
In this lightning talk, I will be exploring the bills of mortality, which track the medical crisis of the Great Plague, which led to the death of more than 100,000 Londoners in 1665. In 1891, the Parish Clerks Company deposited the London Bills of Mortality at Guildhall Library. The earliest printed bills in the collection date from the late 16th century, with a virtually complete run from 1664 to the middle of the 19th century. The bills of mortality record the number of deaths each week and provide a statistical record of disease in London. They began to be produced after an outbreak of plague in 1592, although there are a few earlier instances. From 1603, after another outbreak, they were made on a weekly basis, with a view to giving the authorities and inhabitants full information as to the increase or decrease in the number of deaths. At this time, the bills were edged with a border adorned with skulls and crossbones, skeletons and implements of burial. At the top, the inscription Memento Mori, meaning remember you will die, sits beneath a winged hourglass representing the flight of time. The parish clerks collected and published the information every week. The printed bills were distributed on Thursdays at a subscription charge of a penny a sheet or 4 shillings per annum. They were delivered to the King and the Lord Mayor first by 8 a.m. and then went on sale at 10 a.m. The Bills of Mortality allow historians to trace the relentless march of the Great Plague week by week and parish by parish as it progressed across the city. They show that in September 1665 was the worst month for deaths from plague, which reached 7,165 for the week the 12th to the 19th of September. From 1629, the Bills of Mortality included information about the cause of death with a summary count of those killed by named diseases and casualties. These covered a wide range of illnesses, some of which are readily identifiable to us today, some of which are not. For the week shown here, in addition to the 7,165 individuals who died of plague, other diseases we would recognise include consumption and jaundice. For sudden violent deaths, more details about the circumstances are often provided, as seen here, killed from a fall from the belfry of All Hallows the Great. There are some diseases you may not recognise, such as Tissic, which caused 11 deaths and probably refers to tuberculosis, and also Rising of the Lights, which caused 11 deaths, which would have referred to croup or pleurisy. Those who died as a result of fright, grief, and suddenly are also recorded. So how were these records compiled? The return contained the information the clerk received and diagnosed from the searchers about the cause of death. These searchers were supposedly honest and discreet matrons chosen by the parish and sworn in before a justice of the peace. However, they were sometimes anything but discreet, sober, and honest. They described the disease or corpse to the clerk, but they were poor women and not experts. They were the weak link in the chain, sometimes forced to do the job as they were very poor and threatened with the withdrawal of parish support. This poverty made the likelihood of their being open to bribes increase. And so the information received varied in reliability. Deaths were often misrepresented for generous reasons. For example, the desire to make a decent burial allowable. Nurses often misrepresented plague because they didn't want to be quarantined, because if plague was proved, everyone in the house was locked up for 14 days quarantine and a red cross and Lord have mercy upon us painted on the sealed door. Neighbours did not want the area to be known as plague-ridden, as the plague was viewed as a punishment from God, and some simply believed that plague did not come to the better neighbourhoods. The poor found dead in the street may not have been counted. Reporting of other diseases rose too. The parish clerks' company complained about unlicensed ministers, the removal of dead bodies from one parish to another, private burial grounds, and a shortage of honest searchers affecting the bills. The dissenters were accused of failing to report and misreporting, no access to burials at St Paul's Charterhouse or the ground of hospitals. The parish clerks were overwhelmed and they hoped it would soon die down. Many of them themselves were dying of plague. Therefore, while 68,596 deaths were recorded in the city that year, the true number was probably over 100,000, roughly 15% of London's population.
The floor is now open, so please, I'm glad to see there's a question already in from Rebecca Reed. I'll come to that in a second. But thanks to all our speakers. I have a question to start off with, and in the meantime, if you're thinking of questions on the floor, as I said, please raise a virtual hand if you'd like to come in. I'll bring you in, or put a question in the chat. I have a question to the panelists about what survives in the archives and what doesn't, and I suppose there are two aspects to that. When we think of recent medical emergencies, politically, there's often a tendency to say, if government or if this particular politician or leader had done this, rather than that, i.e. then X thousand people would still be alive, rather than having died. By this we tend to mean if the politician had acted on what we now know to be the best possible advice at the earliest possible time, this would have happened. And yet, very interestingly, in the first presentation by Katie talks in terms of earlier medical emergencies of, she said, confusion and massive opinion. And I think we all kind of recognize that. And it's clearly very important that we understand that in terms of previous medical emergencies. But is there a kind of a teleology in terms of what survives in the archives? Are papers more likely to be preserved on policies and ideas that have proved successful than on the sort of the failed policies, the paths not taken, the crazy ideas? Because those are clearly very important in shaping how policymakers and practitioners react at the time. And I suppose a related question arising from Isabel's presentation, she talks about how events are often misrepresented in the records. And again, we know this in terms of, I suppose, recent medical inquiries. We need to know what's gone wrong at the earliest possible stage and as accurately as possible. But there are all sorts of worries that, being honest about what's gone wrong will end careers, it will get people into trouble, it will lead to claims. And therefore, it's probably not just in the sort of the, earlier periods of the plague when people wanted to misrepresent and massage the record. Isn't this just an ongoing problem with these sorts of emergencies? So how does that shape what survives in the archive and what doesn't? Can I ask our speakers to maybe come in on this and do unmute yourselves? Katie.
So I think what you're really asking about is how is decision-making documented?
Yeah.
And that's such a fascinating question. And I think it's interesting how it stays the same over these centuries and how it changes. Certainly when I started digging into the cholera papers at the RCP, which are copious and quite recently catalogued, so they haven't been studies as much as other papers in our collection. So if anyone's looking for a project, have a look at our cholera papers. I was hoping, as you do, that you'll open up a minute book and it will say the committee to discuss this cholera business met on this date. And then we had this fulsome argument and Dr. So-and-so said we should do this and Dr. So-and-so said we should do this. And that you'd be able to see the workings through of how they actually came to an agreement. And of course, it doesn't really happen like that. Certainly Victorian minute books are really very brief and they'll say the subcommittee assigned to actually write this report reported that they'd written a draft and here is the draft. And you get a little bit of here's a draft and someone said maybe we should take this sentence out, maybe we should add this sentence in. But I think the papers are quite opaque on the actual thought processes and personal arguments that probably went on to devise this material. And that's certainly the case for early material, certainly regarding the RCP's plague advice, which is just minuted in the college annals as a committee went off and wrote it and ta-da, here's the published book. Mm-hmm. And I suppose at that point in history, that's how business was conducted. You had a committee and then it decided something and you wrote up what it had decided. And I think what's interesting is possibly how that has shifted when we think about the modern world and decision making in the modern world, where I think a lot of decision makers are very aware because of things like the infected blood scandal and the long campaign to have that looked into, and the fact that there is now finally this investigation that's been looking at so much material, that people are well aware that their decisions that they document could well be revisited next week, next year, in a decade or two's time. And I wonder how that affects the way that decisions are made. And I think in a way, it's a shame we don't have a government records manager or someone from the National Archives on the call, because I'm sure they have opinions about what material does make it to the National Archives and what doesn't, and the ways that decision makers, without wishing to get too political, may be using routes to discuss their decisions that won't be officially minuted and won't be officially documented for precisely this reason, to cover their own backs. So they've got that plausible deniability.
That's a very interesting point.
So I guess, my summary is there are often these gaps of just the bit you really want to find, but for very different reasons at different points in different points in history.
Thank you. Victoria, Alma, Isabel, would you like to come in on this? Victoria,
I was just going to say about the HIV and AIDS collections. Working with the Infected Blood Inquiry was interesting because they basically trump data protection and copyright and everything, so we had to provide them with everything. And then they come back to us and say, and a lot of our collections are from researchers, so they're definitely kind of not our copyright. But that really kind of felt quite tricky because, you know, some of these people's personal accounts which are closed, but we had to, you know, so that's an issue. As Katie was saying, these public inquiries, and obviously there's been other public inquiries on like child abuse as well, it means that everything is open. You can't put any kind of things in place which you do for other research. And in terms of what survives in the archives, I think the HIV and AIDS records are interesting in terms of, because of the lack of government response and because of the discrimination that people felt. We have records from grassroots organisations, not just us, obviously, other organisations as well. So then you do get a different picture of what was happening, and you don't just need to rely on the official record. And I think that will go forward again with the response to COVID as well. We'll have more evidence of what was happening with the people, whereas obviously traditional archives are more kind of top down and finding out what officially happens. So I think, and it will have happened with other epidemics as well. But I think, just thinking what's not there is very interesting as well. And obviously with all archives, you have to remember what's not there and what's not being collected by a particular institution. And I've been an archivist a long time, but it used to be, just take the important people's records. Don't worry about the other people. Whereas now, obviously, that's hopefully all been turned on its head, and we're less strict on what we take. But obviously, that has an impact on resources, and we're not getting into that now. But I think things like the Infected Blood Inquiry in response to HIV and AIDS does demonstrate how it's great to have records from all areas of society to find out, because it's not just the people making the decisions, that we need to know about.
Thank you very much. Alma, would you like to come in on this?
Yeah, these questions are very interesting for thinking about this earlier context in medieval Europe. The first thing is a question about, the expectations that people had of their government authorities. Potentially, we can think of a different relationship with authorities than the one that we have today, and not necessarily an expectation of accountability, but really more of an awareness that those authorities had power over you, whether it was tax collection or imprisonment or force, and that you needed to acquiesce to follow their directives. There were public health policies in place that I mentioned briefly when I was speaking. Things like directives against contaminated meat in marketplaces, against disposing of rubbish in rivers that were known to have drinking water. And I think those were highly practical. They were about a recognition that if everyone's health was affected, this was not good for the community. But I think that the dynamics functioned in a different way than they do today. And in terms of survival, I think this is very interesting in terms of the kinds of pieces of evidence that we have now. Certainly, the period I was looking at was the period when print was emerging and very rapidly became a very effective means of disseminating information, including about health and sort of public directives about epidemic and kind of situations. we know that the material that survives is just a fraction of what was out there. And this is clear from archival evidence about the scale of production of print presses for this kind of material. And also because many of the sort of urban government pamphlets survive in single copies, plague tracts often survive in single copies or just 2 or 3 copies, and clearly there would have been so many more of those. And it's the kind of material that is rapidly consumed. It's passed from one person to another. It also loses its relevance because when you get the next plague outbreak, there's a new publication and you discard the one that you had before. So there's definitely a question of survival, and it's a kind of almost an inverse survival that, you know, it sort of tells you when you have just a few materials, it suggests that there was so much more out there.
Yeah, Isabel, you want to come? Yeah.
Yeah, I would completely agree with Elma, and a lot of the materials that survives at Guildhall Library, you know, you know, there is very little really in terms there is material, but you know, for example, we have some regulations that were brought in against plague, public health regulations, and they were brought in around 1641, which was ahead of the main outbreak in the Great Plague in 1665. And you know, they aren't so draconian. But then later on, I found some regulations that were brought in probably by the central, you know, the central court, which were far more draconian, which included things like food hygiene and things like that, which weren't included in the earlier regulations. Yeah, so and really considering what happened, one would expect to have found far more copies of those regulations. And so probably there was a sense that they became irrelevant, a bit like the rules that came in with COVID that kept changing, and you know but there is a sense that people were collecting these items. Like, for example, the bills of mortality, I think it's quite important that they were on sale to people. So I guess like people were consuming that information just as we kind of consume today. You know, statistics follow statistics about deaths and numbers of cases. It was very much, you know, that was very much a kind of consuming, you know, they were following it. Also, I think I had something to add as well to, you know, the kind of ridiculous theories about causes to why these things were happening. We have some adverts, for example, with cures for plague, which were a sort of concoction. It was called portable gold that was sold, you know, as a cure for plague. And there were other broadsides with, you know, things that you could burn in your house, like, for example, incense and stuff like that, which also survive. So you do have a sense of the kind of more ridiculous as well as the more kind of sensible. Yeah.
Isabel, there was a question in the chat, just a very factual one. Does Guildhall have a complete run of bills of mortality?
It does from about 1664, and then prior to that, it's more, you know, I think it has one of the most complete runs, but it's sort of more patchy from sort of 1592, and there's a few prior to that as well. Yeah.
There's a question in the chat from Rebecca Reed, and Rebecca was sort of drawing comparisons, I suppose, between earlier views as illness in some way as a moral failing, and the connection with the AIDS crisis, and the sort of suggestions often when epidemics of sorts, health emergencies occur, that in some sense the victims are to blame. Do you see those sorts of parallels between the kind of earlier centuries and 20th, 21st century health emergencies. Isabel.
Oh yes, particularly the emphasis is a lot on God's visitation, a terrible visitation on us because of all the sin, and it was kind of lumped together with the Great Fire as well. You know, here we are. This is because we've sinned. Now we've had this epidemic, and we've also had a fire. A lot of the literature, the printed sources refer to God, and there's also the fact that is the church, the thing that keeps going through the outbreak as well, because it's the thing that's paying for. That's where they're getting the revenues to bring in all the the watching of the houses and things like that. So yes, it's very much a moral and spiritual, tied in with a moral and spiritual element, and also probably because there isn't much other guidance really. Medicine doesn't have a lot to offer people at that point.
I suppose there's a sort of flip side to this. Now I was thinking about this when Elma was speaking, that sometimes we can dismiss references to religion as a kind of pre-scientific approach, but are there also elements from earlier centuries that we can kind of recover in a positive way? I was thinking about Elma's reference to powerlessness, the sense of powerlessness in the medieval world, and I suppose that's something that is still kind of valuable. We tend to assume nowadays that medical technology can solve almost anything, but people inevitably find at a certain stage that medicine is no longer effective, that they are powerless. And understanding how earlier centuries dealt with that sense of powerlessness can be helpful. Likewise, the religious response, although you could dismiss that as pre-scientific, I suppose some people would talk about that now in terms of a kind of holistic approach to well-being, a sense that medicine isn't the beginning and the end of public health. Now, Elma, would you like to respond to that?
Yeah, I think it's really interesting to think about a very different relationship that people had with their bodies and with health, and with their sense of what life involved and the world to come, and that if you place at the center of all your thinking the health of your soul, that shifts your relationship with your body. And sort of really key to medieval thinking about bodily health was that it depended on spiritual health. So if you contracted any kind of illness, if you actually wanted to experience physical recovery, you needed to pay attention to your soul. And then kind of closely associated with that, if it became clear that you were not going to recover physically in a full sense, you could accept that or take that on board, because ultimately what happened to your soul was the most important thing. So it's a different kind of framework for thinking about these matters. And I also think that in a day-to-day sense, it gave people an extra kind of tool in their arsenal, because you could feel that you were doing something if you prayed, or if you reflected on your sins, or if you engaged in a work of charity and you helped someone else, which was a key kind of Christian activity. So it actually gave you something that you could do. And I think that's something really interesting to think about, in terms of dealing with illness and assuaging anxiety about it, is action. And actually, religion is a form of action as well as a form of internal reflection.
Thank you very much indeed. Isabel, would you want to come in?
I'm sorry, I was
No.
Thanks.
Katie, do you? Yeah.
Sort of connected to that and thinking about what the non-scientific side of how we think about health, I guess, and this overall question of why does looking at the history of medicine help us think about health and health crises today? What really struck me across all the presentations was this element of emotion that Victoria started with, one of those absolutely iconic AIDS posters, AIDS Don't Die of Ignorance, which certainly for my generation is just it's one of my first experiences of certainly public health campaigns, but sort of mass advertising campaigns as well. And it has it still packs a huge emotional punch today. And thinking about the Ebola crisis of 2014, again, I think any of us who were kind of aware of the news as that was happening, there was this sense of fear. It was a really interesting sense of fear around that, because it was something about how if it's happening in Africa, that's one thing, but if it starts spreading here, that's something else. Again, there's a lot to unpack in that. But across all of these, there's this. It's very easy to think today that medicine is about science and biochemistry and gene therapy and these very abstruse scientific concepts, but it's ultimately about people's lives. It's about life and death and how we live from day to day. And these are all very salutary lessons in the fact that the emotional import, both for the people experiencing disease, but the people making the decisions about public health, is hugely important, because those prejudices that come into play that say things like, well, AIDS is happening to gay men, so why do we care? Or Ebola is not a problem if it's in Africa, but once it starts spreading on planes, then we've got an issue. Or people being affected by cholera are the poor, so we should say, so from the RCP advice that was given about cholera, there's this line that really caught my eye before that I've just dug out again, that they say, the college will also impress on individuals, especially of the poorer classes, the great importance of well airing their rooms and of cleanliness in both their dwellings and persons. And that sort of paternalistic, moralizing attitude that says, poor people don't know that it's nice to keep their buildings clean. And if we just tell them to do it, then they'll get on and do it, completely ignoring all the structural reasons why they can't keep a clean, dry house, because they haven't got money for fuel or they haven't got time to clean, all that sort of thing. So I just think the overall, how it would translate this into meaningful policy, because I guess throughout certainly the early days of COVID, the element of fear was played to such an extent that it maybe went too far, and it can be counteractive. But just the idea that through looking at these various historical examples, we can use the distance we have to then better understand the emotional responses we have and governments have.
I mean, while you were talking about this, I was thinking about there's a broader question in the chat from Michael about the how developments in public health are related to political systems, and that's obviously a very broad question. You can take in all sorts of ways, but I mean, it relates to what you're talking about, Katie, when you mentioned the AIDS propaganda exercise, which I remember as well. And what was interesting about it, I think, was that the sense that this was not something that ideally the Conservative government, Mr. Thatcher, wanted to talk about. They were not comfortable with issues around sexual health. And yet they were sort of forced into it. And that there seems to be a kind of, certainly a comparison with COVID here, a sort of right-wing libertarian government, Boris Johnson, wasn't really comfortable with the sort of massive state intervention that COVID required. And again, was sort of, you almost had a sense of them doing this against their political instincts. Is that a kind of a broader theme, do you think, in medical history and how it relates to the state? The tension between the nature of the problem and the sort of political instincts of policymakers. No, it's a very, very quick. Victoria.
Well, just to follow up on the HIV and AIDS kind of issue, in our records we have material from Norman Fowler and I think there's notes from Margaret Thatcher saying you cannot say these words when they're talking about, no, she was adamant, you know, there's speeches, isn't there, how we should all be a traditional kind of Christian society. And I think Norman Fowler really had to fight to get the don't die of ignorance, you know, and that was like 1986, 1987. And if you think about, there'd been many deaths before that. So there was a couple of years where there was just wrangling because the majority of the Conservative government on the face of it, you know, just thought, you know, being gay was just wrong, and linking back to the religious kind of issue, there was lots, wasn't there, about, you know, you should be God-fearing, and it's a plague, and they called, well, originally they called it a gay plague, and then they called people in the press and our press cuttings, you know, it's a plague from God, you know, and this is what those people deserve, which is, you know, you look and it's disgusting. But then sometimes you catch stuff going, you know, talking about the kind of medieval period, and you're like, no, this was happening in the 1980s, that people were ostracized, weren't they, because of you know, this infection. So, but yeah, so there's definite evidence in our papers about that, you know, that struggle. And again, you can say in hindsight, you can look back at the decisions people made, but they were in the middle of it, and people, like with the COVID, they didn't agree what was the right way, and all scientists, you know, took a long time to kind of isolate it and find out what it was and how it affected people. So yeah, I don't know what I'm trying to say here, but yeah, there is evidence in our papers about political struggle.
That's really interesting. Thank you. There's a question here, and it relates to mental health issues, but I think I might ask it more broadly. In your various collections, panelists, do you have sort of significant collections on, say, the Black Afro-Caribbean population in the UK, or other diaspora populations specifically? And I, you know, I kind of asked that partly out of self-interest, as someone who's involved in a research project on the kind of long history of the Windrush scandal and the treatment of people of Caribbean origin in the UK, and deportations under the 1958 Mental Health Act were an important part of that narrative, and something that disproportionately impacted, I think, on particularly Jamaicans. So, and any comments on that, please?
No,
Victoria.
we don't.
Yeah,
we do, but within the school there is like a global mental health research centre, but the papers haven't come through to us yet. So I guess that's something that, if we look at gaps in our collections, that's something that we need to think about.
I'd say at the RCP, not that I know of, but that doesn't mean we don't have things that relate tangentially, but we don't have collections that on that sort of, you know, population level. We do have materials that I suppose feed into physicians' understandings of global health. We have 19th century materials where they were sending questionnaires out to all sorts of colonized lands, which then have definitely contributed to understandings of diaspora communities as they ended up in the UK much later, but not those direct collections. I would suggest if you're looking for that sort of thing, Bethlehem Museum of the Mind and the archives there might be a good place to start. They'll have a good overview of mental health collections, I think, if nothing else, if they don't have them themselves.
Emma, did you want to come in?
Yeah, I have a similar answer to Katie. So my sense is that we don't have specialised collections, that we might well have related materials in our 20th and early 21st century archives. I'm thinking, for instance, of the Mind Archive that we hold. So I would encourage anyone to get in touch with us, because we have archivists who can make a specific inquiry into our collections and kind of survey what we could have and help you to find a way into it.
Thank you very much. John Stewart is raising a hand. Can you unmute yourself, and you're able to do that? And if the host, can the host unmute John? Yeah, thank you.
Can you hear me?
Yeah.
Yeah, thanks very much for those presentations. This kind of leads on from the previous discussion, and that's about records which do exist, but which are not necessarily available or immediately available, namely patient records. And as a rule of thumb, these are, in my experience, excuse me, closed for 100 years. But if you go to somewhere like the Wellcome Library, the one I know best, you can sign confidentiality agreements and you anonymize and so on and so forth. If you publish or, I mean, I've done history and policy stuff where I've used material from the Wellcome Library, for example, anonymized material. But this is not uniform across the archives and library community, as it were. So one can have the frustrating experience of going to particularly local authority archives where you might be looking for administrative records, but because there's patient records kind of interleaved with them, you can't get access to the administrative records, which can be very frustrating if you're trying to unpick local authority policy, for example. So that's partly a comment, but that the patient records are extremely hard to come by in some circumstances. But I did wonder, since somebody mentioned the TNA earlier on, whether there was across the sector, as it were, any attempt to have a kind of policy about this sort of thing, about, you know, patient records or individual case records can be accessed under certain circumstances and subject to certain constraints. So that's a very broad question, but I'd be very interested to hear the response.
Would anyone like to come in to answer John's good? Yeah, Isabel.
I don't have an exact answer to that question because we don't have those kind of records, but I was going to point people in the direction of London Metropolitan Archives for the kind of questions about diasporas, you know, like, for example, the Afro-Caribbean community in London, or, for example, the gay community, the LGBT community as well. And they certainly have, I don't work there, but I did do a project with The Guardian where we looked at LGBT history through kind of ephemera from the community, and in that had a lot of public health, how they responded to kind of the public health announcements. So that's well worth a look. And also they also have hospital records, and I think most of the time records are held on the it's about time, isn't it? The amount of time that elapses. But I don't have an answer to John's question, really, unfortunately. Sorry.
Anyone else like to come in on that issue? Yeah, Katie.
Again, I don't have all the ins and outs of archival policy on this because I'm more attuned to ethics issues in rare books than in archives. I mean, Victoria might know more about whether there are sort of a patient advice on patients' records that are promulgated through the archive sector. But what I will say is that I suspect that differences between how accommodating different repositories can be could well come down to how well resourced those repositories are. And if there are issues of some being able to provide confidentiality agreements and to look at materials in detail and work out which bits can and can't be seen, local authority archives probably just don't have the staff to be able to take that much care over things, and so they have to take a risk managed approach and say, we know there's patient information in this, we don't have the staff time to work out which bits can and can't be seen or how we could manage that, so we'll just have to say no to all of it, because there's very, very little money in the sector and not a lot of finance, you know. And I like to think that most archivists are hoping that people will use their records, and it is a shame for them when they can't be used, but it often comes down to really boring practical things. So write and support your archives, tell their governing bodies what they're doing well, and try and get them supported. Sorry, a bit of a cri de coeur, but
do you think, I mean, I don't know whether you oh, Victoria, do you want to come in?
It was just to say, yeah, we are a very small archive, but yeah, we don't really have many patient records, a few in the HIV and AIDS collections. I think, yeah, we would probably take a case by case approach, but I can imagine in a local authority kind of setting, they go to the desk, ask for them, and it's just no. So yeah, I think I completely agree with Katie. It's about resources and yeah, kind of what level of service you can provide.
I mean, just following on from John's question, does anyone know if the Freedom of Information Act has had any impact on the way in which patient records are stored? I mean, presumably there are exemptions over from FOI on medical records, but does it, has it affected the long-term storage of medical records, do you think?
I wouldn't know if it's I did work on a freedom of information inquiry on when I was working at the Guardian,
yeah.
And it was to do with heart operations in and the type of surgery, and I guess and they had the Guardian had obtained the information through the freedom of so that kind of information, which is kind of, you can't identify people, yeah. It's probably quite, you can probably access it after a certain amount of time, but it's when it's, when it can be tracked down to an individual,
yeah.
That's when it's going to be problematic. Yeah.
There's a question. Ramesh has asked a sort of a number of questions on COVID specifically. Ramesh says, do you think that using evidence from the archives on public health education, more could have been done earlier to mitigate the impact of the COVID epidemic? For example, using traditional public media information, social media, helped to reduce the spread of incorrect information about the infection and improve uptake of vaccination in countries where it was low. Anyone feel able to come in on that? It's quite a recent, yeah, Katie.
Probably, but I think the issue is that doing this in the heat of the moment is very, very difficult. And I think it's easy to say, I mean, I know that as someone who was involved in the history of medicine with a network of historians of medicine sort of around me on social media, there was a lot of frustration. There's been a lot of frustration throughout the pandemic at news outlets, politicians discovering things about the way health crises play out that sort of common knowledge in the circles who have looked at it in the past. But the issue is that I don't think you can suddenly realize there's a massive pandemic brewing and then think, oh, how can we use this? I think you need people with this sort of knowledge involved in policy making throughout, and to have an awareness. First of all, you have to have an awareness that you need those people to help, and then you have to have them on board and have those kind of perspectives built in, not from the start, but from before the start, because you can't suddenly kind of turn a switch and say, now we're going to use a historically informed approach.
Yeah.
And as what those would be, I'm not the person to say. I suspect that, I mean, my usual conclusion is that everything could be a bit more nuanced. Perhaps the idea that there's one message that works for everyone is not so great. And I mean, and as for the sort of global implications, the way things play out in different countries with their different histories of epidemics at different points, then it becomes incredibly complicated to work out the best way of doing things.
Anyone else like to, Victoria?
I was going to say, kind of in the past, this was relatively unique, wasn't it, COVID, because it was everyone, and everyone doesn't have the same views about things like vaccination and so I just think they were never going to win. And also compared to, if you look back at the HIV and AIDS, it was public health posters and they did go on TV, but now you've got social media, so whatever message someone puts out, there's an opposing view, isn't there? There's the conspiratorialists, there's people that just don't agree with vaccination for whatever. So now there's more ways that people can feed back and have the discussion, which in lots of ways is good, because you're not just being told a central message by people that you don't necessarily trust either. I think maybe in the past there was maybe people just did trust, you know.
Well, I suppose one of my colleagues, the dean of the school now, Joe Fox, had a little project on COVID disinformation. And I think historians are probably quite good at thinking about those terms, how a medical emergency gets tied up with broader narratives, which you might call conspiracy theories, linking developments in disease and vaccines to other political narratives that people are trying to promote. And I suppose that is a kind of a perennial narrative in history, isn't it? Let me see if there's some questions that we haven't dealt with. Let me read out this question from Gail Barton, so I get it straight. Gail says, given that we know people's attitudes and behaviours, along with the core basics of medical advice, have changed little over hundreds of years, do we need to develop future health policy based on what people are most likely to do, rather than what we hope or want them to do? That's quite an interesting question about how we view sort of human nature as well in terms of kind of medical practice. Would anyone like to comment on that?
Just a quick comment, because I know I've spoken about it. Just came up today earlier. I was in an exercise class with some friends, and we were just talking about vaping, and someone was saying, I live near the O2. Well, you can vape in the O2. So when I read that question, I thought, you can predict, but you can't predict everything. So who would have thought we're trying to reduce smoking? Yeah. But then now vaping has become fairly acceptable if you can do it. You know, so there's no one would have thought that, oh, tobacco company, oh, they're bad. Oh, now they're trying to be a bit. And I was saying, I went to a shopping centre recently, and there was this gorgeous shop front. And I was like, what are they selling? And it was all colourful and fruity. And I thought, oh, it's a cosmetic. And it wasn't. It was a vaping shop, which even to me looked quite attractive. So to a young person, so we can't predict what's going to happen in terms of, and soft news about technology. I wouldn't call it technology as such, but something that was designed to reduce the health impact of smoking might have lots of other impacts in the future, especially on our young people who are doing it quite a lot. So yeah, it's a really interesting question, but I think who would have thought maybe even 5 years ago that now we might have a new health impact of not smoking, which obviously still exists, but vaping. So I think it's just so hard to predict. That was just my little hobby horse that came up on me today, but yeah.
I'm thinking exactly the same thing. I was walking down the street yesterday, and as someone who is pretty much allergic to shops, I thought, oh, that looks really, really pretty. I wonder what it is. And I realised it's absolutely true. Isabel, would you wanted to come in?
I wanted to say that one of the reasons that the government didn't bring in some of the restrictions that would have helped to prevent the stop of COVID was that they said that people will get tired of these things, or they won't follow them. But that seemed to be rather a political statement rather than it wasn't actually borne out by people's behaviour later on. So I think it does become a bit more of a what people want to believe in terms of the politicians who are making the so it's quite a problematic area as far as I'm concerned.
Yeah, and the whole question of how you track popular opinion, I think is something that often is difficult to actually accurately gauge from the historical record, isn't it? Katie, you wanted to come in.
I immediately started thinking about smoking as well when you read that question. But I was thinking about it from a slightly different angle, which was, so we've mostly been talking about infectious diseases, and Elma spoke very clearly about the way these diseases were perceived as an attack, like a violent attack on the body. And all these diseases we've been talking about are, life and death issues, very violent attacks. And it's interesting maybe it shouldn't have been a surprise that people can be reluctant to do things that are quite simple and straightforward to protect themselves from these diseases, especially if we think about COVID mitigations. When we stop and think about the ways people have been and continue to be willing to put their bodies in danger of horrible outcomes voluntarily by smoking. And maybe there are an awful lot of lessons that we can learn, and I'm sure people are thinking about, from anti-smoking campaigns when we think about public health campaigns for diseases and things, because people still choose to smoke tobacco, knowing absolutely full well what it could do to them and what it will do to them. But the way people deal with that sort of nebulous risk, invisible risk, is very telling, I think, in the way that people then deal with the invisible risk of COVID infection.
Yeah, and this comes, it comes down to a comment that Liz Bosch has put in the chat. Says, I suspect the lessons from history for newer behavioral economists on how we incorporate nudge theory into public health policy. Much of how people respond to campaigns is working at an emotional level, and history is a good way of revealing the roots of people's responses to authority messages. It's a very interesting point. Anyone like to respond to that? Yeah, Kate.
Yeah, sorry, me again, but just thinking about that authority point, and thinking back to the AIDS campaigns, I think Victoria mentioned about how an awful lot of the records are grassroots because government wasn't doing much.
Yeah.
And I think we often think about then AIDS attempts to stem the spread of AIDS as being government campaigns, but actually there's that huge grassroots movement as well. And I think there's something really interesting about people were seeing everyone they knew die, and they were doing things to try and stop it.
Yeah.
And that's one sort of site of authority, isn't it? The fact that your community is being decimated, more than decimated, and your community newspaper is just made of obituaries. And then on the other side, the fact that when the government does start to do something about it, people aren't necessarily paying attention to that supposed site of authority, because it doesn't come with authority, because it waited so long to act, and it doesn't have the authenticity of the grief. And so I think I don't know how we translate that into something useful to try and get people to live more healthily, but there's something about that. People are very attuned to motives, aren't they? And what authority isn't just being elected, it's about what people perceive your motives to be for the messages you give.
That may be the point at which we have to end. We've got to 12:30. It's been a fantastic discussion. Thank you so much to our panelists. I think it's been really interesting. Thanks for really interesting, incisive questions as well from the audience.